The blood was everywhere, and Dr. Rebecca Chen was throwing up in the supply closet for the third time that week. Outside, the emergency sirens wailed through the corridors of St. Mary's Hospital in downtown Chicago, but inside that cramped space between medical supplies and cleaning equipment, she was fighting a battle she seemed destined to lose. Her hands shook as she gripped the metal shelving, her pristine white coat now stained with evidence of her weakness. The other combat medics had started calling her Queasy Becky behind her back, though they were careful never to let Chief Medical Officer Thompson hear them. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed, because tomorrow I've saved something extra special for you. The whispers followed Rebecca through every corridor of the trauma center like shadows she couldn't escape. At 28 years old, she possessed all the technical qualifications that should have made her an asset to the emergency medical team. Her medical degree from Northwestern University was impeccable, her residency performance had been exemplary, and her written examinations consistently ranked in the top 5% of her class. But when the ambulances screamed into the emergency bay with their cargo of broken bodies and shattered lives, Rebecca Chen became a different person entirely. She would freeze at the sight of arterial bleeding, her face turning pale as winter snow. The metallic smell of blood would trigger waves of nausea that left her doubled over in whatever private space she could find. During her first week on the trauma team, she had actually fainted during a routine appendectomy, hitting the floor so hard that she required 3 stitches on her forehead. The incident became legendary among the medical staff, passed down through generations of residents like a cautionary tale about the difference between book learning and real-world application. Dr. Marcus Thompson, the chief medical officer who had personally recruited Rebecca from her residency program, watched this transformation with growing concern and bewilderment. He had seen her academic records, had interviewed her extensively, and had been impressed by her theoretical knowledge and her apparent dedication to emergency medicine. Her understanding of trauma protocols was sophisticated, her diagnostic capabilities were exceptional, and her bedside manner with conscious patients showed genuine compassion and professionalism. But the moment real crisis entered the equation, Rebecca Chen seemed to vanish, replaced by someone who looked exactly like her, but possessed none of her apparent capabilities. The other members of the trauma team had mixed reactions to Rebecca's struggles. Some, like Dr. Jennifer Walsh, felt genuine sympathy for someone who was clearly suffering and trying desperately to overcome what appeared to be a psychological barrier. Walsh had worked with Rebecca during quiet night shifts and had seen flashes of the competent physician that Rebecca's academic record suggested she should be. During routine procedures, when the pressure was low and the stakes manageable, Rebecca demonstrated skills that impressed even experienced trauma surgeons. Her suturing technique was precise and elegant, her knowledge of anatomy was comprehensive, and her ability to explain complex medical procedures to worried family members was both clear and comforting. But Dr. Kevin Morrison, a 15-year veteran of emergency medicine, had less patience for what he perceived as weakness in a field where hesitation could mean the difference between life and death. Morrison had seen too many medical professionals who looked good on paper but crumbled under the intense pressure of trauma medicine. In his experience, the emergency department was no place for people who couldn't handle the sight of blood or the reality of human suffering. He had lobbied quietly but persistently for Rebecca's transfer to a less demanding department, arguing that keeping her on the trauma team was not just inefficient, but potentially dangerous for patients who needed immediate, confident medical intervention. The divide in opinions about Rebecca created an undercurrent of tension in the emergency department that affected everyone who worked there. Some staff members went out of their way to protect her from the most challenging cases, while others seemed to take a perverse pleasure in watching her struggle with situations that they handled routinely. The result was a fractured team dynamic that made everyone's job more difficult and created an atmosphere of uncertainty about who could be counted on when crisis struck. Rebecca was acutely aware of these dynamics and carried the weight of disappointment and judgment with her through every shift. She had entered emergency medicine with genuine passion for helping people in their most vulnerable moments, but that passion was being systematically crushed by her inability to function effectively when it mattered most. The worst part was that she couldn't explain her reactions even to herself. She had dissected cadavers in medical school without difficulty, had observed numerous surgeries during her residency, and had even assisted in several complex procedures without incident. But something about the emergency department, with its chaos and urgency and life-or-death pressure, triggered responses that she couldn't control or understand. Her nights were haunted by dreams of patients she had failed to help, scenarios where her weakness had contributed to suffering or death. She would wake up in cold sweats, her heart racing as she relived moments of paralysis and inadequacy. The dreams were becoming more frequent and more vivid, bleeding into her waking hours and making it difficult to concentrate during routine tasks. She had considered seeking professional help, but the stigma surrounding mental health issues in the medical profession made her reluctant to admit that she might need psychological intervention. The breaking point seemed to be approaching rapidly. Rebecca had overheard Chief Thompson discussing her future with the hospital administration, conversations that clearly indicated that her position on the trauma team was being seriously questioned. The hospital couldn't afford to maintain a physician who couldn't perform her basic duties, regardless of her potential or her academic credentials. The healthcare industry was too demanding and too competitive to carry people who couldn't handle the fundamental requirements of their chosen specialty. What made Rebecca's situation even more frustrating was that she genuinely cared about her patients and wanted desperately to be the doctor she had trained to become. She spent her off hours reading medical journals, attending continuing education seminars, and practicing procedures on training dummies. Her theoretical knowledge continued to expand, and she could discuss complex medical cases with sophistication and insight. But when faced with actual bleeding patients and real emergencies, all of that knowledge seemed to evaporate, leaving her paralyzed and useless. The other trauma team members had developed various strategies for working around Rebecca's limitations. Dr. Walsh would quietly reassign her to less critical cases when possible, while Dr. Morrison would simply take over whenever Rebecca showed signs of distress. The nurses had learned to watch for the telltale signs of Rebecca's impending breakdown and would discreetly redirect her attention to tasks that didn't involve direct patient care. These well-intentioned efforts to protect both Rebecca and the patients had the unintended consequence of further isolating her from the core work of the department and reinforcing her reputation as someone who couldn't be counted on when it mattered most. Rebecca's personal life was also suffering under the strain of her professional struggles. She had moved to Chicago specifically for this position, leaving behind family and friends in California who had been so proud of her acceptance into such a prestigious trauma program. Phone calls home became increasingly difficult as she tried to maintain the fiction that everything was going well while dealing with the reality of her failing career. Her parents, both successful professionals themselves, had invested enormous emotional and financial resources in her medical education and had always spoken with pride about their daughter, the doctor. The thought of disappointing them added another layer of pressure to an already impossible situation. The financial implications of potential failure were also weighing heavily on Rebecca's mind. Medical school had left her with substantial student loan debt, and her current salary was barely enough to cover her living expenses and loan payments. If she lost her position on the trauma team, finding another job in emergency medicine would be extremely difficult, given the tight-knit nature of the medical community and the way that professional reputations followed physicians throughout their careers. She might be forced to consider entirely different medical specialties, which would require additional training and potentially years of additional debt. During her rare moments of self-reflection, Rebecca sometimes wondered if she had chosen the wrong profession entirely. Perhaps she was simply not cut out for the high-stress world of emergency medicine, regardless of her academic preparation and genuine desire to help people. Maybe she should consider transitioning to a field like family practice or radiology, where the pace was slower and the pressure less intense. But giving up on emergency medicine felt like admitting defeat, like acknowledging that she wasn't strong enough or capable enough to do the work she had always dreamed of doing. The irony of her situation was not lost on Rebecca. She had entered medicine specifically because she wanted to make a difference in people's lives during their most critical moments. She had been drawn to emergency medicine by the challenge and the opportunity to use her skills in life-or-death situations. But instead of becoming the confident, competent physician she had envisioned, she had become exactly the opposite. Someone whose presence in critical situations might actually make things worse rather than better. Dr. Thompson had tried to be supportive, offering additional training opportunities and suggesting various strategies for managing what he diplomatically referred to as her, quote, adjustment challenges. He had arranged for Rebecca to work with the hospital's employee assistance program, providing access to counseling and stress management resources. But these well-intentioned interventions hadn't addressed the core problem, and Rebecca's performance continued to deteriorate despite everyone's efforts to help her succeed. The most painful aspect of Rebecca's situation was the knowledge that she was letting down not just herself and her colleagues, but potentially the patients who needed her help. Emergency medicine was built on the principle that every member of the team had to be reliable and competent, that there was no room for weak links when human lives were at stake. By remaining in a position she couldn't effectively fill, Rebecca was compromising the integrity of the entire trauma program and potentially putting patients at risk. Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. As Rebecca stood in that supply closet, fighting off another wave of nausea after witnessing a particularly gruesome motorcycle accident victim, she felt the weight of all these pressures crushing down on her. The victim had been conscious and screaming, his leg twisted at an impossible angle and blood pooling beneath him on the emergency department floor. Rebecca had taken one look at the scene and had immediately felt the familiar churning in her stomach, the lightheadedness that preceded her inevitable retreat to the nearest private space. Dr. Morrison had stepped in without comment, taking charge of the situation with the kind of calm confidence that Rebecca envied and desperately wished she could emulate. The patient had been stabilized and rushed to surgery within minutes, the kind of efficient response that demonstrated exactly why the trauma team couldn't afford weak members. Rebecca's absence during those critical moments had been noted by everyone present, adding another entry to the growing catalog of her professional failures. Standing among the medical supplies and cleaning equipment, Rebecca realized that she was approaching a crossroads that would determine the entire future trajectory of her career and her life. She could continue struggling in a position where she was clearly failing, hoping against hope that something would change and she would suddenly develop the psychological resilience that emergency medicine required. Or she could acknowledge that she had made a mistake in choosing this specialty and begin the difficult process of transitioning to something more suitable for her temperament and capabilities. Neither option felt acceptable to Rebecca. Continuing in her current role meant subjecting herself to ongoing humiliation and professional failure while potentially compromising patient care. But abandoning emergency medicine felt like giving up on everything she had worked toward, everything she had dreamed of becoming since she first decided to pursue medicine as a career. The sense of being trapped between two impossible choices was overwhelming, and Rebecca felt tears of frustration and despair beginning to well up in her eyes. What Rebecca didn't know, as she stood in that supply closet fighting her inner demons, was that her entire understanding of her own history and capabilities was built on incomplete information. There were aspects of her past that had been deliberately obscured, experiences that had been classified and buried so deeply that even she had no conscious memory of them. The medical records that had followed her through medical school and residency contained carefully crafted omissions, gaps that had been created to protect not just Rebecca, but national security interests that extended far beyond the walls of St. Mary's Hospital. The nausea and paralysis that seemed to define Rebecca's response to medical emergencies were not signs of weakness or incompetence, but rather symptoms of psychological conditioning that had been designed to suppress memories and capabilities that someone had determined were too dangerous to remain accessible. The very reactions that were destroying her medical career were actually evidence of training and experience that went far beyond anything taught in medical school. Experiences that had been deliberately locked away for reasons that Rebecca couldn't possibly understand. Dr. Thompson, watching Rebecca's struggles from his position as chief medical officer, carried knowledge about her background that weighed heavily on his conscience. His recommendation to recruit Rebecca for the trauma team hadn't been based solely on her academic credentials, though those were certainly impressive. Thompson's own background included connections to military and intelligence communities that most of his colleagues knew nothing about, and his interest in Rebecca Chen was based on information that existed in files she would never be allowed to see. The irony of Rebecca's situation was profound and tragic. The same psychological conditioning that was making her appear weak and incompetent in civilian emergency medicine had once made her one of the most effective combat medics in the most dangerous theaters of operation in the world. The skills that were now suppressed had once saved hundreds of lives under conditions that would have broken most medical professionals. But those memories and capabilities had been locked away so thoroughly that Rebecca herself had no conscious access to them, leaving her to struggle with civilian medical emergencies while possessing unconscious expertise that far exceeded anything her current colleagues could imagine. The supply closet where Rebecca sought refuge contained cleaning supplies and medical equipment that would have been familiar to her in contexts she couldn't remember, environments where such basic materials had been the difference between life and death for wounded soldiers and civilians caught in conflicts that officially didn't exist. Her hands, which now shook at the sight of blood in a sterile hospital environment, had once performed complex surgical procedures under enemy fire, using improvised instruments and working by flashlight while explosions shook the ground around her. But all of that was buried beneath layers of psychological conditioning that had been designed to protect both Rebecca and the classified operations she had participated in. The government agencies responsible for that conditioning had determined that allowing her to retain conscious memory of her combat medical experience would pose unacceptable security risks, and they had been willing to sacrifice her civilian medical career to maintain the secrecy of operations that the public would never know about. Dr. Morrison, despite his apparent lack of patience with Rebecca's struggles, was also carrying knowledge that complicated his assessment of her situation. His own military background included exposure to classified medical programs, and he recognized signs in Rebecca's behavior that suggested far more complex psychological dynamics than simple squeamishness or lack of confidence. Morrison's harsh attitude toward Rebecca was actually a protective mechanism, designed to maintain distance from someone whose true background he suspected but couldn't acknowledge without compromising his own security clearances. The emergency department where Rebecca worked was not a randomly chosen assignment, but rather a carefully orchestrated placement that served multiple purposes for various government agencies. St. Mary's Hospital had connections to military and intelligence medical research programs that dated back decades, and several key staff members held security clearances that allowed them access to information about patients and personnel that went far beyond normal medical records. Rebecca's assignment to this particular trauma team was part of a larger plan to monitor and evaluate the effectiveness of the psychological conditioning that had been applied to her memories. As Rebecca finally composed herself enough to leave the supply closet and return to her duties, she was unaware that her every reaction was being carefully observed and documented by people whose real purpose in the hospital extended far beyond providing medical care. The reports being generated about her performance weren't just going to hospital administration, but were also being forwarded to agencies that maintained ongoing interest in the long-term effects of memory suppression techniques on former military medical personnel. The patients who entered St. Mary's emergency department brought with them not just medical emergencies, but also opportunities for the hospital's classified research programs to gather data about trauma response, stress reactions, and the effectiveness of various psychological interventions. Rebecca's struggles with blood and violence weren't just personal failures, but were also valuable data points in ongoing studies about the long-term consequences of classified military medical training programs. The city of Chicago itself had been chosen as the location for this phase of Rebecca's evaluation because its high crime rates and frequent medical emergencies provided a constant stream of cases that would test her psychological conditioning under various types of stress. The urban environment offered opportunities to expose her to situations that might trigger suppressed memories, while also providing cover for the various government personnel who maintained surveillance on her activities both inside and outside the hospital. Rebecca's apartment, located just a few miles from the hospital, was in a building that housed several other individuals who were unknowingly participants in similar psychological monitoring programs. The seemingly random neighbors and casual acquaintances who had entered her life since moving to Chicago were actually carefully selected individuals whose job was to observe and report on her behavior in non-medical contexts. Even her social interactions and personal relationships were being evaluated as part of the ongoing assessment of her psychological stability and security risk profile. The medical journals that Rebecca read in her spare time, the continuing education seminars she attended, and the training materials she used to practice procedures were all carefully curated to avoid triggering memories that might compromise the psychological conditioning that kept her previous experiences buried. The very dedication to improving her medical skills that she saw as evidence of her commitment to her profession was actually being manipulated to reinforce the barriers that prevented her from accessing the capabilities that could make her an exceptional trauma physician. Dr. Thompson's office contained files about Rebecca that went far beyond her official medical school transcripts and residency evaluations. Hidden in a secure safe that required multiple forms of authentication were psychological profiles, mission reports, and medical evaluations that documented her performance in combat situations that had never been officially acknowledged by any government agency. Those files contained evidence of medical achievements that would have made her a legend in trauma medicine if they could ever be revealed. The most tragic aspect of Rebecca's situation was that the very memories and skills that had been suppressed to protect national security were exactly what she needed to succeed in her current position. The confidence, the steady hands, the ability to function effectively under extreme pressure, all of these qualities existed within her, locked away by psychological conditioning that prevented her from accessing her own capabilities when she needed them most. As Rebecca returned to her duties in the emergency department, trying once again to convince herself that she could overcome her limitations through determination and practice, she was unaware that the solution to her professional struggles lay buried in her own suppressed memories. The combat medic who had once performed surgery under fire for 6 hours straight, saving dozens of lives in conditions that would have been unimaginable to her civilian colleagues, still existed somewhere within her psychological architecture. But accessing that version of herself would require breaking through conditioning that had been designed by some of the most sophisticated psychological manipulation techniques ever developed by government agencies. The question was not whether Rebecca Chen had the capability to become an exceptional trauma physician, but whether the forces that had buried her previous identity would allow her to reclaim the skills and confidence that could save not just her career, but potentially countless lives in the years to come. The pressure began building 3 weeks later when Rebecca found herself assigned to the overnight shift during what the hospital staff euphemistically called the Devil's Weekend. Friday night through Sunday morning in downtown Chicago meant a steady stream of gunshot wounds, stabbings, overdoses, and trauma cases that would test even the most experienced medical professionals. Dr. Morrison had specifically requested that Rebecca be scheduled for these shifts, claiming it was time to determine once and for all whether she belonged in emergency medicine. Rebecca knew this was her final examination, though nobody had explicitly stated it. The way conversation stopped when she entered the break room, the carefully neutral expressions on her colleagues' faces, and Dr. Thompson's increasingly frequent visits to observe her work all pointed to an evaluation period that would determine her future at St. Mary's Hospital. The weight of this knowledge sat heavy in her chest as she prepared for what might be her last chance to prove herself worthy of the trauma team. The first case arrived at 11:30 on Friday night, brought in by paramedics whose grim expressions told the story before they spoke a word. A 17-year-old boy named Marcus Williams had been caught in crossfire between rival gangs, taking 3 bullets to his torso while walking home from his job at a local grocery store. The paramedics had managed to stabilize him during transport, but his condition was deteriorating rapidly, and the emergency department team had only minutes to save his life. Rebecca felt the familiar churning in her stomach as she looked at the blood-soaked teenager being wheeled into Trauma Bay 3. His mother arrived moments later, screaming his name and trying to push past security to reach her son. The combination of Marcus's labored breathing, the metallic smell of blood, and his mother's anguished cries created exactly the kind of chaotic, high-pressure environment that had consistently triggered Rebecca's most severe reactions. Dr. Morrison watched her carefully, waiting for the inevitable moment when she would excuse herself and disappear, leaving the real medical professionals to handle the crisis. But something different happened that night. As Rebecca approached Marcus's bedside and saw the fear in his eyes, a strange calmness began to settle over her. The nausea that usually overwhelmed her senses seemed to recede, replaced by a focused clarity that allowed her to process the medical information with unusual precision. She found herself moving with confidence she didn't recognize, her hands steady as she began examining the entry wounds and assessing the extent of internal damage. Dr. Morrison stepped forward, expecting to take over as he always did, but Rebecca's voice cut through the chaos with an authority that surprised everyone in the trauma bay. She rattled off a series of medical orders with such precision and confidence that the nurses responded immediately, recognizing competent leadership when they heard it. Her assessment of Marcus's condition was rapid but thorough, and her treatment plan demonstrated a level of expertise that seemed to come from nowhere. The transformation was so dramatic that Dr. Walsh actually stopped what she was doing to stare at Rebecca in amazement. This was not the same physician who had been struggling with basic trauma cases for months. Rebecca's movements were efficient and purposeful, her medical decisions were sound and well-reasoned, and her ability to maintain focus despite the chaos around her was remarkable. She worked on Marcus for 2 hours, stabilizing his condition and preparing him for emergency surgery with a skill level that impressed even Dr. Morrison. Marcus Williams survived because of Rebecca's intervention, but the victory felt hollow to her as she tried to understand what had happened during those crucial hours. The confidence and competence she had displayed seemed to have come from outside herself, as if someone else had temporarily taken control of her body and mind. The experience left her with fragments of sensations and images that felt familiar but couldn't be placed, like echoes of dreams she couldn't quite remember. Dr. Thompson observed this transformation with a mixture of satisfaction and concern that his colleagues couldn't understand. For him, Rebecca's sudden display of advanced trauma skills wasn't mysterious or surprising, but rather confirmation of capabilities that he had always known existed within her. The question wasn't whether she possessed exceptional medical training, but whether the psychological conditioning that suppressed those abilities was beginning to break down under the pressure of repeated exposure to trauma situations. The success with Marcus Williams marked the beginning of a pattern that would define the next several weeks of Rebecca's professional life. During routine cases and low-pressure situations, she continued to struggle with the same limitations that had plagued her since arriving at St. Mary's. But when truly critical emergencies arose, when lives hung in the balance and split-second decisions were required, Rebecca would undergo the same transformation that had saved Marcus's life. These episodes of exceptional competence were becoming more frequent and more pronounced, but they were also accompanied by troubling side effects that Rebecca couldn't explain or control. After each incident, she would experience severe headaches that lasted for hours, accompanied by vivid dreams that felt more like memories than products of her imagination. The dreams always took place in settings she didn't recognize, treating patients whose injuries were unlike anything she encountered in civilian emergency medicine. The most disturbing aspect of these dreams was their incredible detail and medical accuracy. Rebecca would find herself performing complex surgical procedures using techniques and equipment that she had never been trained to use, yet her dream self handled them with expert precision. She operated in environments that looked like military field hospitals, treating wounds that suggested combat rather than civilian accidents. The patients in her dreams spoke languages she didn't recognize, but somehow she understood them perfectly and could communicate complex medical information without difficulty. Dr. Morrison's attitude toward Rebecca began to shift as he witnessed more of these dramatic transformations. His initial skepticism gave way to professional curiosity, then to something approaching concern as he recognized patterns in her behavior that reminded him of his own experiences with military medical personnel who had been exposed to classified training programs. Morrison's own background included service in special operations medical units, and he had encountered other physicians whose civilian careers had been complicated by suppressed memories of military medical training. The emergency department staff started referring to Rebecca's episodes of exceptional competence as her switch flips, and they learned to recognize the subtle signs that preceded these transformations. Her posture would straighten, her voice would take on a different quality, and her eyes would develop a focused intensity that was completely unlike her normal demeanor. During these episodes, Rebecca would demonstrate knowledge and skills that far exceeded her supposed training, using medical terminology and procedures that weren't part of standard civilian emergency medicine curriculum. Nurse Patricia Williams, a 20-year veteran of emergency medicine who had worked with hundreds of physicians, found Rebecca's transformations deeply unsettling. Patricia had seen doctors grow and develop their skills over time, had watched residents gradually gain confidence and competence through experience and training, but Rebecca's sudden shifts from incompetence to expertise were unlike anything in Patricia's professional experience. It was as if two completely different physicians were occupying the same body, alternating control based on circumstances that Patricia couldn't predict or understand. The patients who benefited from Rebecca's transformed state had no idea that they were receiving care from someone whose abilities seemed to fluctuate based on invisible psychological triggers. A construction worker named James Rodriguez, brought in after falling 3 stories from scaffolding, experienced the full extent of Rebecca's hidden capabilities when his multiple injuries required simultaneous treatment for internal bleeding, spinal trauma, and severe lacerations. Rebecca worked on James for 4 hours, performing procedures that pushed the boundaries of what was possible in an emergency department setting. During James's treatment, Rebecca demonstrated knowledge of advanced surgical techniques that she shouldn't have possessed, using innovative approaches to controlling bleeding and stabilizing fractures that impressed even the orthopedic surgeons who were called in to consult. Her ability to prioritize multiple life-threatening injuries and coordinate complex treatment protocols suggested experience with mass casualty situations that went far beyond anything available in civilian medical training. James Rodriguez walked out of the hospital 6 weeks later, with functionality that doctors had initially thought impossible to preserve. But Rebecca's memory of treating James was fragmented and inconsistent, filled with gaps that she couldn't explain. She remembered the beginning of his case and the final outcome, but the hours of intense medical intervention in between felt like someone else's experiences that had been described to her secondhand. The disconnect between her apparent actions and her conscious memories was becoming increasingly disturbing, and Rebecca began to worry that she might be experiencing some form of psychological breakdown that was affecting her perception of reality. Dr. Thompson's monitoring of Rebecca's condition involved resources and expertise that extended far beyond normal hospital protocols. His office contained communication equipment that allowed him to maintain contact with government agencies that had ongoing interest in Rebecca's psychological development. The reports he filed about her episodes of enhanced competence were carefully analyzed by specialists who understood the long-term effects of classified military medical training programs and the psychological conditioning used to suppress memories of sensitive operations. These government specialists were particularly interested in the circumstances that triggered Rebecca's transformations, looking for patterns that might indicate whether her suppressed memories were beginning to surface naturally, or whether external intervention might be required to maintain the psychological barriers that kept her previous experiences buried. The balance between allowing her to function effectively as a civilian physician and maintaining the security of classified operations was delicate, and any significant change in her psychological state required careful evaluation and potential intervention. Rebecca's personal life was also showing signs of strain as her professional struggles intensified. She had tried to maintain relationships with colleagues and develop friendships outside the hospital, but the fragmentary nature of her memories and the inconsistency of her personality were making genuine connections increasingly difficult. People who met Rebecca during her episodes of enhanced competence were often confused and disappointed when they encountered her normal, struggling persona during routine social interactions. Dr. Lisa Martinez, a psychiatrist who worked part-time at St. Mary's, had begun observing Rebecca informally after noticing the dramatic variations in her behavior and apparent capabilities. Martinez's own background included exposure to military psychological research, and she recognized signs that suggested Rebecca might be experiencing the long-term effects of advanced psychological conditioning. But any formal evaluation of Rebecca's mental state would require authorization from agencies that Martinez couldn't contact through normal channels. The most challenging aspect of Rebecca's situation was that her episodes of enhanced competence were becoming psychologically addictive. During those moments when she functioned as an exceptional trauma physician, Rebecca felt a sense of professional satisfaction and personal fulfillment that was completely absent from her normal experiences. The confidence, the competence, and the ability to save lives under extreme pressure were everything she had dreamed of when she chose emergency medicine as her specialty. But these episodes were beyond her conscious control, and she couldn't access those capabilities when she needed them most. The addiction to these moments of competence was creating a dangerous psychological dynamic where Rebecca began to crave increasingly intense emergency situations, hoping that the pressure and chaos would trigger the transformation that made her feel like the physician she wanted to be. She started volunteering for the most challenging cases, seeking out opportunities to work with the most critically injured patients, driven by a desperate need to access capabilities that felt like her true self but remained frustratingly elusive. Dr. Morrison recognized the signs of this psychological pattern and became increasingly concerned about Rebecca's safety and judgment. Physicians who developed addictions to high-stress medical situations often made poor decisions about their own limitations, taking on cases that exceeded their abilities or pushing themselves beyond safe working conditions. Morrison had seen military medics develop similar patterns after returning from combat, unable to find satisfaction in routine medical practice after experiencing the intense focus and purpose that came with treating life-threatening injuries under extreme conditions. The hospital administration was also taking notice of Rebecca's unusual pattern of performance. Quality assurance reviews of her cases showed dramatic variations that were difficult to explain through normal medical evaluation criteria. Her most successful interventions demonstrated expertise that seemed far beyond her supposed training and experience, while her failures showed basic competency issues that were inconsistent with someone capable of such advanced medical performance. The documentation of these variations was creating a medical record that didn't make sense according to standard professional development patterns. Insurance companies and medical licensing boards were beginning to ask questions about Rebecca's credentials and training background, prompted by case reviews that showed evidence of medical techniques and knowledge that weren't part of standard emergency medicine curricula. The gaps in her educational record that had once seemed like minor administrative oversights were now attracting attention from investigators who specialized in verifying physician qualifications and detecting fraudulent medical credentials. Rebecca's student loan records were also under review by federal agencies that maintained interest in monitoring the financial activities of individuals with connections to classified government programs. The loans that had funded her medical education had been processed through programs that included provisions for loan forgiveness in exchange for service commitments that Rebecca had no conscious memory of making. These financial arrangements were creating paper trails that connected her to government agencies and military medical programs that officially didn't exist. The apartment building where Rebecca lived was under surveillance by teams that maintained 24-hour observation of her activities outside the hospital. The reports generated by this surveillance documented behavioral patterns that suggested increasing psychological instability, including sleep disturbances, social isolation, and symptoms of post-traumatic stress that were inconsistent with her supposed civilian medical background. The surveillance teams were particularly interested in monitoring for any signs that Rebecca might be attempting to research her own background or recover suppressed memories through independent investigation. Dr. Thompson's role in monitoring Rebecca's condition was becoming increasingly complex as various government agencies developed different assessments of the risks and benefits associated with her continued employment at St. Mary's Hospital. Some agencies favored allowing her to continue developing her capabilities naturally, viewing her episodes of enhanced competence as evidence that she could eventually become a valuable asset in civilian emergency medicine without compromising operational security. Other agencies advocated for immediate intervention to reinforce the psychological conditioning that kept her memory suppressed, arguing that any risk of exposure outweighed the potential benefits of her medical contributions. The decision about Rebecca's future was further complicated by the fact that she was not the only former military medical personnel being monitored through similar programs. St. Mary's Hospital was part of a network of medical facilities that served as placement locations for physicians whose backgrounds included exposure to classified military medical training. The psychological conditioning techniques used to suppress their memories were still experimental, and Rebecca's case was providing valuable data about the long-term effectiveness and potential side effects of these programs. The other physicians in this monitoring program were experiencing varying degrees of success in their civilian medical careers, but Rebecca's case was unique in the dramatic nature of her transformations and the advanced level of medical expertise she displayed during episodes of enhanced competence. Her case was being studied by specialists who were interested in understanding whether the psychological barriers that suppressed her memories could be partially lowered to allow access to her medical skills without compromising the security of her operational memories. As Rebecca continued working through her series of overnight shifts during the Devil's Weekend, she remained unaware that her every action was being analyzed by teams of specialists who understood her background better than she did herself. The medical emergencies that arrived in St. Mary's Emergency Department were providing opportunities to test the limits of her psychological conditioning and evaluate the stability of the memory suppression techniques that had been applied to her consciousness. The most critical test would come during the early hours of Sunday morning, when a mass casualty incident would arrive at St. Mary's that would push Rebecca's capabilities to their absolute limits. The psychological pressure of that situation would force a confrontation between her suppressed memories and her conscious mind that would determine not just her future as a physician, but potentially her survival as the person she believed herself to be. The forces that had created Rebecca Chen were about to discover whether their psychological conditioning was strong enough to withstand the most extreme test that civilian emergency medicine could provide. The explosion happened at 3:17 on Sunday morning, shattering windows for 6 blocks and sending a fireball into the Chicago sky that could be seen from Lake Michigan. A natural gas leak in the basement of the Meridian apartment complex had been ignited by a faulty water heater, creating a blast that collapsed 2 floors and trapped dozens of residents beneath tons of concrete and twisted metal. The emergency dispatch system immediately activated the hospital's mass casualty protocol, And within minutes, every available medical professional in the city was being called to assist with what would become the largest urban rescue operation in Chicago's recent history. Rebecca was finishing her paperwork from a routine overdose case when the first wave of victims began arriving at St. Mary's. The paramedics who wheeled them through the emergency department doors were covered in dust and blood, their faces grim with the knowledge that what they were bringing represented only the beginning of a flood of human suffering that would continue for hours. The injuries were unlike anything the hospital had seen in years, with victims suffering from severe burns, crush injuries, respiratory damage from smoke inhalation, and trauma wounds that would challenge even the most experienced medical teams. Dr. Thompson immediately activated the hospital's disaster response plan, transforming the entire emergency department into a coordinated treatment facility designed to handle the massive influx of critical patients. Additional medical personnel were called in from off-duty shifts, surgical suites were prepared for continuous operation, and supply chains were activated to ensure adequate resources for extended emergency operations. The hospital's communication center became a command post coordinating with fire departments, police units, and other medical facilities throughout the metropolitan area. Rebecca watched the controlled chaos unfolding around her with a mixture of terror and anticipation that she couldn't fully understand. The familiar nausea was beginning to build in her stomach as she observed the severity of the injuries being brought into the trauma bays, but there was something else stirring beneath her conscious awareness, something that felt like recognition rather than fear. The sounds of organized emergency response, the urgent communication between medical teams, and the sight of multiple critical patients being treated simultaneously triggered sensations that felt hauntingly familiar, despite her inability to place them in any context she could remember. The first patient assigned to Rebecca's care was Maria Santos, a 34-year-old mother of 3 who had been pulled from the rubble after being trapped for nearly 2 hours. Maria's injuries included severe burns across 40% of her body, multiple rib fractures, and internal bleeding that required immediate surgical intervention. The complexity of her condition meant that Rebecca would need to coordinate with burn specialists, thoracic surgeons, and hematologists while maintaining Maria's stability during the critical first hours of treatment. As Rebecca approached Maria's bedside, she felt the familiar sensation of her consciousness shifting into a different mode of operation. The transformation was more dramatic than anything she had experienced before, accompanied by a clarity of thought and purpose that felt like coming home after a long journey. Her movements became precise and economical, her medical assessments rapid but thorough, and her communication with the nursing staff took on an authority that brooked no argument or hesitation. Dr. Morrison, observing from across the trauma bay, recognized immediately that something extraordinary was happening. Rebecca's handling of Maria's complex injuries demonstrated expertise that went far beyond civilian emergency medicine training. She was using advanced burn treatment protocols that were typically taught only in specialized military medical facilities, applying pressure techniques for internal bleeding that suggested experience with combat injuries, and coordinating multiple treatment priorities with an efficiency that spoke of extensive practice in mass casualty situations. The most remarkable aspect of Rebecca's performance was her apparent ability to process and prioritize vast amounts of medical information simultaneously, while maintaining perfect situational awareness of everything happening around her. She managed Maria's immediate treatment needs, while simultaneously monitoring the conditions of patients in adjacent trauma bays, anticipating resource needs before they became critical, and providing guidance to other medical staff who were struggling with their own complex cases. Dr. Walsh found herself drawn to observe Rebecca's work, fascinated by the transformation that had turned their struggling colleague into what appeared to be one of the most competent trauma physicians she had ever seen. Rebecca's diagnostic capabilities seemed almost supernatural in their accuracy and speed, and her treatment decisions consistently proved to be exactly what each situation required. Walsh began documenting everything she observed, recognizing that she was witnessing something that would need to be carefully analyzed and understood. Maria Santos survived the first critical hours because of Rebecca's intervention, but she was only the beginning of what would become the most challenging night of Rebecca's professional life. As more victims arrived from the apartment complex explosion, Rebecca found herself assigned to increasingly complex cases that would have challenged teams of specialists working together. A construction worker who had been trapped beneath a concrete beam required immediate amputation of his crushed leg. performed under emergency department conditions that pushed the boundaries of what was medically possible outside a surgical suite. The amputation procedure demonstrated capabilities that Rebecca shouldn't have possessed, using techniques that were typically taught only in forward surgical teams deployed in combat zones. Her ability to maintain the patient's stability while performing major surgery under suboptimal conditions suggested experience with field medicine that went far beyond anything available in civilian medical training. Dr. Morrison watched the entire procedure with growing recognition of patterns he had observed in special operations medical personnel, who had served in the most dangerous theaters of military operation. Rebecca's consciousness during these procedures existed in a strange state of dual awareness, where she could observe her own actions while feeling disconnected from the expertise she was demonstrating. Her hands moved with practiced precision through surgical procedures she had no memory of learning, while her mind provided medical knowledge that seemed to come from sources she couldn't identify. The disconnect between her actions and her conscious understanding created a surreal experience where she felt like she was watching someone else save lives using her body as an instrument. The psychological strain of maintaining this level of medical performance while dealing with the cognitive dissonance of her fragmented memories was enormous. Between patients, Rebecca would experience moments of disorientation where she couldn't clearly distinguish between her current environment and other settings that felt equally real but couldn't be placed in any timeline she could remember. The emergency department of St. Mary's Hospital would occasionally seem to overlap with images of field hospitals in desert environments, treating patients whose injuries suggested conflicts that didn't exist in any official records. Dr. Thompson's monitoring of Rebecca's condition during the mass casualty event involved real-time communication with government specialists who were evaluating the psychological risks associated with her extended exposure to high-stress medical situations. The reports he transmitted included detailed observations of her behavioral changes, assessments of her emotional stability, and evaluations of whether her suppressed memories were beginning to surface in ways that might compromise operational security. The specialists monitoring Rebecca's case were particularly concerned about the duration and intensity of her enhanced performance during the apartment complex emergency. Previous episodes had lasted only hours and had involved single patients or small groups, but the current situation was forcing her to maintain advanced medical capabilities for an extended period while treating dozens of critically injured victims. The psychological conditioning that suppressed her memories had never been tested under such extreme circumstances, and there was genuine concern about what might happen if the barriers between her conscious mind and her suppressed experiences began to break down completely. Rebecca's treatment of burn victims throughout the night demonstrated knowledge of advanced techniques that were classified within military medical research programs. Her ability to assess burn severity, manage pain protocols, and coordinate complex wound care suggested experience with injuries typically seen only in combat environments or terrorist attacks. The specific medications she requested and the treatment sequences she employed matched protocols that were used in classified military medical facilities but were not part of standard civilian burn treatment guidelines. The most challenging case of the night arrived at dawn when firefighters brought in Detective Robert Kim, a police officer who had been leading rescue operations inside the collapsed building, when a secondary collapse trapped him beneath debris for over 3 hours. Kim's injuries included severe spinal trauma, massive internal bleeding, and crush syndrome that threatened to cause complete organ failure. His condition was so critical that most of the medical staff assumed he wouldn't survive long enough for meaningful intervention. Rebecca's assessment of Detective Kim's condition was rapid and comprehensive, identifying treatment priorities that other physicians had missed, and implementing interventions that stabilized his condition when everyone else had assumed he was beyond saving. Her management of his spinal injuries demonstrated expertise with battlefield trauma that suggested experience treating similar injuries under combat conditions. The techniques she used to address his internal bleeding were innovative approaches that combined traditional surgical methods with field medicine adaptations that maximized effectiveness under emergency conditions. Dr. Morrison realized during Rebecca's treatment of Detective Kim that he was observing medical capabilities that exceeded anything he had seen in his own military medical service. The precision of her diagnostic assessments, the sophistication of her treatment protocols, and her ability to improvise solutions to complex medical problems suggested training and experience that represented the highest levels of military medical expertise. Morrison's own background included exposure to special operations medical training and he recognized techniques and approaches that were taught only to medical personnel selected for the most sensitive and dangerous military assignments. The transformation in Rebecca's demeanor and capabilities was so complete that nurses who had worked with her for months barely recognized her as the same person who had been struggling with routine emergency cases just weeks earlier. Her communication style had shifted to the precise, economical language of someone accustomed to coordinating complex medical operations under extreme pressure. Her situational awareness extended throughout the entire emergency department, and she seemed to instinctively understand the capabilities and limitations of every medical professional working around her. Patricia Williams, the veteran emergency department nurse, found herself following Rebecca's lead despite having 20 years more experience in trauma medicine. There was something about Rebecca's presence and authority during the mass casualty event that commanded respect and confidence from everyone who worked with her. Patricia had served with military medical units earlier in her career, and she recognized the quality of leadership that was typically found only among the most elite medical professionals who had proven themselves under the most challenging conditions imaginable. The psychological conditioning that had been designed to suppress Rebecca's memories was beginning to show signs of strain under the prolonged exposure to situations that closely resembled her classified military medical experience. The government specialists monitoring her case were observing behavioral changes that suggested the barriers between her conscious mind and her suppressed memories were becoming increasingly permeable. The concern was not just about her psychological stability, but about the possibility that she might begin to recover specific memories of classified operations that could compromise ongoing national security interests. Dr. Thompson received authorization to implement emergency psychological intervention protocols if Rebecca's condition showed signs of complete breakdown, but the decision about when to intervene was complicated by her extraordinary effectiveness in treating the mass casualty victims. The lives being saved by her enhanced capabilities had to be weighed against the security risks associated with allowing her suppressed memories to continue surfacing. The ethical implications of deliberately impairing a physician's ability to save lives in order to protect classified information created moral dilemmas that had no clear resolution. Rebecca's treatment of pediatric victims from the apartment complex explosion was particularly revealing of the depth of her suppressed medical training. Her ability to adapt adult trauma protocols for children, her expertise with pediatric medication dosages, and her skill in managing the unique psychological challenges of treating injured children all suggested extensive experience that went far beyond standard medical school training. The techniques she employed were consistent with specialized military medical programs that trained personnel to treat civilian populations in conflict zones where children were frequently among the casualties. The most disturbing aspect of Rebecca's enhanced performance was her apparent emotional detachment from the human suffering she was treating. While her medical interventions were compassionate and highly effective, her psychological response to the injuries and trauma around her was markedly different from her normal empathetic reactions to patient suffering. She functioned with the clinical efficiency of someone who had seen similar injuries countless times before, processing human tragedy as medical data, rather than experiencing the emotional impact that typically affected civilian medical personnel. Dr. Martinez, the psychiatrist who had been informally observing Rebecca's behavioral patterns, recognized signs of psychological dissociation that were consistent with advanced military psychological conditioning. The ability to maintain emotional distance from traumatic situations while preserving full cognitive and technical capabilities was a characteristic that was deliberately developed in military medical personnel who were expected to function effectively in extreme combat environments where emotional reactions could compromise their ability to save lives. The apartment complex explosion had created exactly the kind of mass casualty situation that Rebecca's suppressed military medical training had been designed to address. The combination of multiple critically injured patients, limited resources, suboptimal treatment conditions, and extended duration of operations closely resembled the combat medical scenarios where her buried expertise had been developed and refined. The psychological triggers that activated her enhanced capabilities were responding to environmental cues that matched her suppressed training experiences with remarkable precision. As the mass casualty event extended into its 12th hour, Rebecca had treated over 30 critical patients with a success rate that exceeded anything in St. Mary's hospital records. Her interventions had saved lives that other medical professionals had considered beyond saving, and her coordination of treatment resources had maximized the effectiveness of the entire emergency response effort. The statistical analysis of her performance during the apartment complex emergency would eventually become a case study in exceptional medical crisis management, though the true explanation for her capabilities would never be included in any official documentation. The physical and psychological strain of maintaining such intensive medical performance for an extended period was beginning to show effects that concerned Dr. Thompson and the specialists monitoring Rebecca's condition. Her enhanced capabilities seemed to be drawing on psychological and physiological resources that were not sustainable indefinitely, and there were signs that the conditioning that suppressed her memories was beginning to break down under the pressure of prolonged activation. Detective Kim's recovery became a symbol of Rebecca's extraordinary capabilities during the mass casualty event. His survival and eventual return to full function would have been impossible without the immediate and sophisticated medical intervention that Rebecca provided during the critical first hours after his rescue. The techniques she employed to address his spinal injuries and internal trauma were later analyzed by specialists who confirmed that her treatment protocols were among the most advanced approaches available in military medical literature, though they couldn't explain how a civilian emergency physician had acquired such expertise. The final patient of the night was 8-year-old Timothy Chen, who had been trapped in an air pocket created by collapsed furniture and had survived for nearly 10 hours before rescue teams could reach him. Timothy's injuries included severe dehydration, hypothermia, and psychological trauma that required careful coordination between emergency medical treatment and psychiatric intervention. Rebecca's approach to Timothy's case demonstrated sensitivity to the unique needs of pediatric trauma patients that suggested extensive experience treating children in crisis situations. Rebecca's interaction with Timothy revealed aspects of her personality that had been completely suppressed during her episodes of enhanced medical performance. Her natural empathy and compassion emerged as she worked to gain the frightened child's trust while providing the medical care he needed to survive. The contrast between her clinical efficiency with adult patients and her gentle, nurturing approach with Timothy suggested psychological complexity that went beyond simple medical training and indicated deep personal experience with protecting vulnerable individuals in dangerous situations. As dawn broke over Chicago and the last of the apartment complex victims were stabilized and transferred to appropriate treatment facilities, Rebecca found herself standing in the emergency department that had been transformed by 12 hours of intensive medical crisis management. The exhaustion she felt was unlike anything she had experienced in civilian medicine, a bone-deep weariness that seemed to come from sources beyond physical fatigue and suggested psychological resources that had been pushed to their absolute limits. Dr. Thompson approached Rebecca as she completed her final patient documentation, recognizing that the mass casualty event had created a psychological crisis that would require immediate intervention. The barriers that had suppressed her memories for years had been severely compromised by the prolonged exposure to situations that matched her military medical training, and there were clear signs that her conscious mind was beginning to access experiences that had been deliberately hidden from her awareness. The moment of recognition came when Rebecca looked at her reflection in the emergency department's medical cabinet glass and saw not the struggling civilian physician who had been fighting to prove herself worthy of the trauma team, but someone else entirely. The face looking back at her was that of Major Rebecca Chen, United States Army Special Operations Medical Corps, veteran of classified operations in 3 different conflict zones, and holder of commendations that would never appear in any official records accessible to civilian authorities. The memories didn't return all at once, but rather began surfacing in fragments that connected her current medical performance with experiences that had been locked away by psychological conditioning, designed to protect both her civilian identity and the operational security of missions that officially never happened. The apartment complex emergency had pushed her psychological barriers beyond their breaking point, and the person she had been before the conditioning was beginning to reassert control over her consciousness and capabilities. Dr. Morrison watched this transformation with a mixture of professional fascination and personal concern, recognizing that they were witnessing the breakdown of one of the most sophisticated psychological conditioning programs ever implemented by military intelligence agencies. The woman standing before them was no longer the struggling civilian physician who had been questioning her competence and fighting to overcome what appeared to be psychological limitations, but rather a highly trained military medical professional whose true capabilities had been deliberately suppressed for reasons that extended far beyond her personal career concerns. The implications of Rebecca's memory recovery extended far beyond her individual situation, and touched on classified military medical programs that involved dozens of other personnel who had been transitioned to civilian careers with similar psychological conditioning. The success or failure of Rebecca's reintegration would influence policy decisions about how to handle other former military medical personnel whose memories had been suppressed to protect national security interests, while allowing them to continue their medical careers in civilian settings. Rebecca's recognition of her true identity created an immediate crisis for the government agencies that had been monitoring her civilian medical career. The psychological conditioning that had kept her military medical experience suppressed was designed to be permanent, and its breakdown suggested either fundamental flaws in the program or external factors that hadn't been anticipated by the specialists who had implemented her memory suppression. The possibility that other conditioned personnel might experience similar breakdowns under stress created security concerns that extended throughout the intelligence community. The most immediate challenge was determining how to handle Rebecca's situation now that she was beginning to recover memories of classified military operations. Her knowledge of special operations medical techniques, her awareness of classified research programs, and her familiarity with personnel and facilities that were never officially acknowledged represented security risks that required careful evaluation and potentially immediate intervention to prevent unauthorized disclosure of sensitive information. As Rebecca stood in the emergency department, surrounded by the evidence of her extraordinary medical performance during the apartment complex crisis, she realized that everything she had believed about herself and her capabilities had been based on deliberately false information designed to hide her true identity and experience. The struggling civilian physician had been a carefully constructed facade that had concealed one of the most highly trained military medical professionals in the United States Armed Forces, and the time for maintaining that deception was rapidly coming to an end. The secure conference room on the 15th floor of St. Mary's Hospital had never hosted a meeting quite like this one. Dr. Thompson sat across from Colonel David Hayes, a man whose official title was Director of Military Medical Transition Services, but whose actual role involved managing the civilian careers of former Special Operations medical personnel, whose memories had been classified beyond top-secret clearance levels. Between them sat Rebecca, no longer the uncertain physician who had struggled with basic emergency procedures, but Major Rebecca Chen, whose recovered memories now included 3 tours of duty in locations that didn't exist on any official maps. Colonel Hayes spread a collection of photographs across the conference table, each one showing Rebecca in military medical gear treating casualties in environments that looked like scenes from a war movie. The first photograph showed her performing emergency surgery in what appeared to be a bombed-out building, her hands steady as she worked on a wounded soldier while explosions illuminated the night sky outside. The second captured her treating civilian casualties in a marketplace that had been targeted by terrorists, her medical equipment improvised from supplies that would have been considered inadequate by civilian emergency medicine standards. Rebecca stared at these images of herself, feeling the strange sensation of watching memories click into place like pieces of a complex puzzle. She remembered the weight of the body armor she wore in these photographs, the smell of cordite and smoke that had become as familiar as antiseptic and cleaning supplies. Most vividly, she remembered the absolute clarity of purpose that had driven her through 18-hour surgical marathons in field hospitals, where the line between life and death was measured in seconds, and the difference between success and failure often came down to improvisation and raw determination. The mission that had ended her military career was documented in a file so heavily redacted that entire pages contained nothing but black ink, but the photographs told the story that the written reports couldn't reveal. Rebecca had volunteered for assignment to a medical unit supporting a classified operation to extract American civilians from a terrorist-controlled city in a country that officially denied the presence of any U.S. military personnel. The mission had required her to establish and operate a field hospital in the basement of a destroyed building while under constant enemy fire. For 6 days and nights, Rebecca had provided emergency medical care to wounded extraction team members and rescued civilians while the building above her was systematically destroyed by artillery bombardment. Her medical supplies had been limited to what could be carried in by special operations personnel, and her surgical equipment had consisted mainly of instruments designed for battlefield use rather than complex medical procedures. The patients she treated included children who had been caught in crossfire, elderly civilians suffering from malnutrition and disease, and soldiers whose injuries would have challenged the resources of a fully equipped trauma center. Colonel Hayes explained that Rebecca's psychological conditioning had been implemented not as punishment or discipline, but as protection for both her and the classified operations she had participated in. The techniques and protocols she had developed during her military medical service represented innovations that were years ahead of civilian emergency medicine, and her knowledge of special operations medical capabilities could have compromised ongoing missions if it had become accessible to foreign intelligence services or even domestic medical researchers who weren't cleared for such information. The decision to suppress Rebecca's military medical memories had been made at the highest levels of military intelligence, with input from specialists who understood both the security implications of her knowledge and the personal toll that carrying such memories would exact on someone trying to rebuild a normal civilian life. The psychological conditioning had been designed to allow her to pursue her medical career while protecting her from the trauma associated with her combat experiences and preventing unauthorized disclosure of classified medical techniques. Dr. Thompson revealed that St. Mary's Hospital had been selected as Rebecca's placement location specifically because of its connections to military medical research programs and its staff's experience working with former military personnel who required special consideration. Several other physicians at the hospital were veterans of classified medical operations, though most had undergone less extensive memory suppression than Rebecca's case had required. The hospital served as a kind of halfway house for military medical professionals, transitioning to civilian careers while managing the psychological and security challenges associated with their backgrounds. Rebecca's recovery of her military memories was creating complications that extended far beyond her individual situation. The psychological conditioning that had suppressed her experiences was supposed to be permanent, and its breakdown suggested potential problems with similar programs affecting other former military medical personnel. Intelligence agencies were concerned that if Rebecca could recover her memories spontaneously, other conditioned personnel might experience similar breakdowns that could compromise ongoing operations or reveal classified information to unauthorized individuals. The apartment complex emergency had created exactly the kind of psychological pressure that the conditioning had been designed to withstand, but the duration and intensity of the crisis had exceeded the parameters that the program's designers had anticipated. Rebecca's natural medical instincts and her genuine commitment to saving lives had fought against the artificial barriers that kept her capabilities suppressed, and her unconscious mind had eventually found ways to access the training and experience she needed to function effectively during the mass casualty event. Colonel Hayes presented Rebecca with a choice that would determine the rest of her professional and personal life. She could undergo renewed psychological conditioning that would again suppress her military memories and allow her to continue her civilian medical career without the complications associated with her classified background. The process would be more sophisticated than the original conditioning, incorporating techniques that had been developed based on lessons learned from cases like hers, and it would theoretically allow her to function as a highly competent civilian physician without retaining conscious access to her military medical experience. Alternatively, Rebecca could choose to retain her recovered memories and accept assignment to a classified military medical research facility where her combat medical expertise would be used to develop new techniques and protocols for treating casualties in special operations environments. This option would mean abandoning her civilian medical career and returning to military service under cover identities that would prevent her from maintaining normal personal relationships or establishing roots in any civilian community. The third option was the most difficult and uncertain. Rebecca could attempt to integrate her military and civilian medical identities, working as a civilian physician while retaining her military memories and expertise. This choice would require ongoing monitoring by intelligence agencies and periodic psychological evaluations to ensure that she didn't inadvertently compromise classified information. It would also mean accepting responsibility for protecting national security interests while pursuing her civilian medical career under conditions that would always involve some level of government oversight. Rebecca's decision was complicated by her growing understanding of how her suppressed military experience had shaped her civilian medical struggles. The nausea and paralysis that had plagued her during routine emergency cases hadn't been signs of weakness or incompetence, but rather psychological defense mechanisms that had been designed to prevent her from accessing capabilities that were supposed to remain classified. Her apparent failures as a civilian trauma physician had actually been evidence that the conditioning was working as intended, protecting classified information by making it impossible for her to demonstrate the full extent of her medical training and experience. Dr. Walsh and the other medical staff who had witnessed Rebecca's transformation during the apartment complex emergency were debriefed by intelligence personnel who explained the security considerations associated with her case without revealing specific details about her military background. The staff members were required to sign non-disclosure agreements that prohibited them from discussing Rebecca's enhanced medical performance or speculating about the source of her apparent expertise. The most profound impact of Rebecca's memory recovery was her recognition of how much of her identity and self-worth had been built on false information. The struggling physician who had questioned her competence and fought to prove herself worthy of the trauma team had never really existed. Rebecca Chen had always been an exceptional medical professional, whose capabilities had been deliberately hidden from her own consciousness to protect national security interests that she had served with distinction and honor. Rebecca's choice ultimately came down to a question of authenticity versus security. She could choose to return to the carefully constructed facade of the struggling civilian physician, accepting the psychological conditioning that would again hide her true capabilities and experience. Or she could embrace her authentic identity as a military medical professional whose training and experience represented the highest levels of combat medical expertise, accepting the complications and restrictions that came with retaining classified knowledge and capabilities. The decision she made would affect not just her own life, but the lives of future patients who might benefit from her extraordinary medical skills and the security of ongoing military operations that depended on protecting the techniques and protocols she had helped develop. Rebecca realized that her choice would also influence how similar cases were handled in the future, potentially affecting dozens of other former military medical personnel who were managing their own transitions from classified service to civilian careers. Standing in that conference room, surrounded by photographs that documented a version of herself she was only beginning to remember, Rebecca felt the weight of responsibility that came with possessing knowledge and capabilities that could save lives, but also compromise national security. The woman who had spent months questioning her fitness for emergency medicine was discovering that she was actually one of the most qualified trauma physicians in the country, with experience treating injuries and managing medical crises under conditions that most civilian medical professionals could never imagine. Rebecca's final decision reflected her understanding that authentic service meant using her capabilities to their fullest extent while accepting responsibility for protecting the sources of those capabilities. She chose to retain her military memories and work as a civilian physician under the ongoing oversight of intelligence agencies, becoming a bridge between military and civilian emergency medicine, while maintaining the security protocols necessary to protect classified information. The integration of Rebecca's military and civilian medical identities transformed St. Mary's Hospital into an even more effective trauma treatment facility. Her expertise with combat medical techniques improved the hospital's ability to treat complex trauma cases, while her experience with mass casualty situations enhanced the effectiveness of the hospital's disaster response protocols. The hospital became a model for how former military medical personnel could contribute to civilian healthcare while maintaining appropriate security safeguards. Rebecca's story became a legend within the classified military medical community, inspiring changes in how former special operations medical personnel were transitioned to civilian careers. Her case demonstrated that the complete suppression of military medical experience wasn't necessary to maintain operational security, and that carefully managed integration of military and civilian medical expertise could benefit both national security interests and civilian healthcare capabilities. Years later, Rebecca would look back on her struggle to understand her apparent medical limitations as a necessary journey toward accepting her authentic identity and capabilities. The woman who had once hidden in supply closets to avoid confronting her perceived weaknesses had become a respected leader in emergency medicine, whose influence extended far beyond St. Mary's Hospital, teaching other medical professionals techniques and approaches that had been forged in the crucible of combat medical service. The compass that had guided her through the darkest moments of her civilian medical struggles now sat on her desk, as a reminder that true direction came not from hiding from difficult truths, but from embracing them with courage and wisdom. Rebecca Chen had learned that the greatest strength came not from perfect performance under ideal conditions, but from the willingness to serve others regardless of the personal cost or professional risk involved. 5 years had transformed Rebecca Chen from the uncertain physician who once fled to supply closets into the most respected trauma surgeon in Chicago. The emergency medicine conference at Northwestern University buzzed with anticipation as she stepped onto the stage, her confident stride bearing no resemblance to the hesitant woman who had once questioned every medical decision she made. The auditorium, filled with medical professionals from across the nation, had come to hear Dr. Chen present her groundbreaking research on trauma response integration, though none of them knew the true source of her revolutionary techniques. Her presentation slides showed statistical improvements in patient survival rates that had made St. Mary's Hospital the premier trauma center in the Midwest, with outcomes that surpassed even specialized military medical facilities. Rebecca's voice carried the authority of someone who had earned respect through actions rather than titles as she addressed the audience. Her opening statement challenged conventional wisdom about emergency medicine training, suggesting that the most effective trauma physicians were those who could maintain absolute clarity under the most chaotic conditions. The medical students in the front rows took careful notes, recognizing they were learning from someone whose reputation had become legendary in emergency medicine circles. Dr. Morrison, now serving as Rebecca's research partner, watched from the wings as she demonstrated techniques that had been adapted from classified military protocols for civilian emergency medicine use. The irony wasn't lost on him that the woman he had once dismissed as too weak for trauma medicine was now teaching advanced, life-saving procedures to physicians who considered themselves experts in their field. The highlight of Rebecca's presentation was a case study analysis of the apartment complex emergency that had changed everything for her and countless patients. Without revealing the classified aspects of her background, she explained how extreme crisis situations could reveal capabilities that remained dormant under normal circumstances. Her statistical analysis showed that medical professionals often possessed far greater potential than traditional training methods allowed them to access. Young medical residents approached Rebecca after her presentation with questions that reflected their struggle to understand how someone could develop such exceptional trauma medicine skills. Her answers focused on the importance of authentic service, suggesting that true medical excellence came from complete dedication to patient welfare rather than personal recognition or professional advancement. Dr. Thompson, observing from the back of the auditorium, felt deep satisfaction watching Rebecca's transformation complete its evolution. The classified monitoring programs had ended years earlier, replaced by informal oversight that ensured her continued security compliance while allowing her to maximize her contribution to civilian emergency medicine. Her case had become a model for successfully integrating former military medical personnel into civilian healthcare without compromising either national security or medical effectiveness. Rebecca's influence extended far beyond her direct patient care to the training programs she had developed for emergency medicine residents. Her teaching philosophy emphasized psychological resilience, technical precision, and ethical clarity under pressure. The physicians who trained under her supervision consistently demonstrated superior performance in high-stress medical situations, carrying her principles into hospitals throughout the country. The private moment Rebecca treasured most came during quiet night shifts when she could walk through St. Mary's emergency department and observe the seamless operation of medical teams whose training reflected her integrated approach to trauma medicine. The department that had once been divided by uncertainty and inconsistency now functioned with the precision and confidence of a special operations unit, treating every patient with capabilities that honored the full potential of emergency medicine. Rebecca's personal relationships had also found stability as she learned to balance her authentic identity with the security requirements of her background. Her marriage to Dr. James Liu, a cardiologist who understood the demands of high-stakes medicine, provided emotional anchor that grounded her intense professional commitments. Their partnership demonstrated that authentic relationships were possible, even when built around carefully maintained boundaries regarding classified information. The medical research foundation that Rebecca established used anonymous funding to support innovations in trauma medicine that bridged military and civilian applications. Young physicians received grants to develop techniques that could save lives in both combat and civilian emergency situations, advancing medical science while maintaining appropriate security protocols. Her foundation's work influenced emergency medicine development worldwide, though its true origins remained protected information. Rebecca's legacy was measured not in recognition or awards, but in the lives saved by physicians who had learned from her example and training. Emergency departments across the nation reported improved patient outcomes after implementing protocols that Rebecca had developed, and medical schools integrated her teaching methods into their trauma medicine curricula. The ripple effects of her authentic service continued expanding, touching patients and medical professionals who would never know her name. The most profound transformation was within Rebecca herself, who had learned that true strength came from embracing authentic identity rather than hiding from difficult truths. The woman who had once questioned her worthiness to practice emergency medicine had become living proof that the greatest medical achievements came from complete dedication to serving others, regardless of personal cost or professional risk. Standing before her bathroom mirror each morning, Rebecca saw reflected back someone who had found peace with the complexity of her identity and purpose. The face looking back was that of a physician who had learned to integrate all aspects of her experience into service that honored both her military training and her civilian medical calling. The internal conflict that had once paralyzed her had been replaced by clarity of purpose that made every decision straightforward. Rebecca Chen had discovered that heroes weren't created by recognition or circumstances, but by the choice to use whatever capabilities they possessed in service of others who needed protection and healing. Her story became whispered inspiration among medical professionals who faced their own struggles with identity and purpose, proving that authentic service could transform both the server and those being served. The compass that had once guided her through the darkest moments of uncertainty now sat in her office as a reminder that true direction came from internal clarity rather than external validation. Rebecca had learned that the most important navigation came from understanding one's authentic purpose and having the courage to serve that purpose regardless of obstacles or limitations. As she prepared for another shift in the emergency department that had become her true home, Rebecca carried with her the knowledge that every patient she treated benefited from the full integration of her experience, training, and dedication. The woman who had once hidden from her own capabilities now stood as an example of what became possible when authentic identity was embraced, in service of something greater than personal comfort or convenience. Up next, you've got two more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out.